Welcome, everyone. This is just to say that we're going to give it just another 5 minutes as people are still logging on, and then we'll be starting. Thank you.
Yeah.
Parliamentary staff in sub-Saharan Africa to support engagement in women's, children's, and adolescent health. We're going to start now, and I'm going to ask everyone as they log on if they can go on mute. I want to start by, on behalf of the organizers, the Partnership for Maternal, Newborn, and Child Health, the Interparliamentary Union, the World Health Organization, the Africa Population and Health Research Center, Countdown to 2030, and Living Goods. I want to thank you all for your interest and for joining us today. We know these are busy times and really appreciate your presence. My name is Kedi Touré. I lead the parliamentary work at the Partnership for Maternal, Newborn, and Child Health, and I'll be guiding you through the conversation today. As you will have seen in the objectives of this webinar, in the whole series, is to introduce you to some of the key issues related to women's, children's, and adolescent health, and to share information that will help you analyze budgets with a health lens, and to enable you to ensure that legislation across sectors supports improved health outcomes. Today, the first in a series of 3, we'll be focusing on women's, children's, and adolescent health trends. We'll start off with a word of welcome from Martin Chungong, who's the Secretary General of the Interparliamentary Union. Then we will move on to get a presentation from Nancy Kidula from the WHO Afro office, who will walk us through trends in women's, children's, and adolescent health, including challenges and situations. She will also provide us with an overview of the impact of COVID-19 on these health outcomes, as we're seeing some indirect impacts of the pandemic on access to essential health services. We'll proceed to have some time for conversation and questions on that presentation. And then we'll move on to a presentation from Cheikh Faye, who's the head of the West Africa Regional Office of the Africa Population and Health Research Center. This presentation will focus on inequalities. And then we'll have a little bit more time for conversation. We want this session to be as interactive as possible. So please feel free to use the chat box as people are presenting, to ask any questions that you have, to make any comments that you want to make, and also to share your experience. We've heard from a number of you in writing over the past couple of days that you'd also be interested in hearing about how different parliaments are dealing with the issue. Feel free to use this opportunity to share. We also ask that everyone go on mute. So that we can hear the presenters adequately. We're going to start incessantly, just a couple of announcements. You will have received background documents in the email that provided you with the dial-in details. Among those, you'll see a BMJ series on women's, children's, and adolescent health, a number of regional reports issued by WHO, and then you'll have a folder for each country that actually provides scorecards or profiles on maternal newborn health and then on inequalities. So feel free to dig into those for information specifically related on your country's data. We will also use that same folder to provide you with the presentations for this webinar, so you will have access to that as well. This webinar is being recorded, so we will provide you with a link to this recording that you can share with partners and colleagues that weren't able to join the webinar. And finally, you will have received a link to a survey that provides us with information about your expectations for the webinar, about your levels of knowledge that help us shape the different webinars. So grateful if you can take 5 to 10 minutes to fill that out so that we can have webinars that are tailored to your needs. Without further ado, I'm going to ask Martin to welcome us through so that we can start this webinar. Martin.
Can you hear me now?
Perfectly.
Hello. Okay. Thank you very much, Kadi. I'm thrilled to be with you all today, dear participants. And as you can see, I'm not working from my office, my official office. I'm working from home. This testifies to the very special times we are experiencing now. And I am very pleased that all the participants have found time to participate in this very important webinar. In fact, this is, as you have said, Kelly, a series of webinars that are going to be run for parliamentary staff in cooperation between PMNCH, the IPU, the World Health Organization, Countdown to 2030, Living Goods, and all of that. So I want to thank our partners for really coming together to put together this very important tool for participants. As I said, we are dealing with very special times, and the current pandemic shows how important health is for the well-being of mankind. Special measures have been taken, and although we do know that there has been no focus on maternal, child and adolescent health, we do think that it is important that we give priority to the protection of the vulnerable. And this group of persons belong to that category. So I am very heartened that we are able to come together today. Although the statistics, excuse me, the statistics that we have available show that the situation is very dire. I hear that some 300,000 women die from preventable causes related to pregnancy and childbirth every year. And 2/3 of these deaths occur in sub-Saharan Africa. So I think that just this statistic itself kind of challenges us to do something about protecting the health of mothers and by extension, children and adolescents. So I am very pleased that we can organize this webinar at a very timely moment, and it would help us prioritize women, children and adolescents in the interventions that are being made. Let me really underscore the importance of parliamentary staff. Generally, when we talk of parliaments, people look at just parliamentarians, the political personalities and stakeholders, but they do not always understand that the parliamentary administration is the backbone of the institution, the backbone that provides support for political decisions to be made on the basis of facts and accurate research. And that is why we think that this webinar is important, because it is meant to build the capacity of parliamentary staff who then would provide better services to members of parliament as they are called upon to take special decisions during special times. Without trying to take up much of your time, I just want to say that the IPU is committed to this endeavor. You can count on us, because that is part of our long-standing mandate, making sure that parliaments, including all the relevant stakeholders, parliamentarians, parliamentary staff, other partners, can work together in a more robust manner in order to achieve outcomes that are consonant with the real interests and I would say concerns of the people. So thank you very much for giving me this opportunity to say a few words of welcome to this seminar. Please do know that the IPU, in partnership with PMNCH, will continue to extend the support that is possible and necessary for you to perform your duties in support of parliamentarians. Thank you very much.
Thank you so much, Martin. And I want to personally extend my thanks to the IPU for their unwavering support for the issue of women, children's, and adolescent health. I think that Martin has highlighted of investing in women's, children's, and adolescent health, but also has started to paint what a burden they face in terms of mortality and morbidity. And so without further ado, I'm going to pass over to Dr. Kidula, Nancy from Afro, to walk us through what the stats look like.
Thank you, Kadi. I hope that everyone can hear me clearly.
Perfectly.
Thank you for this opportunity to just give us a snapshot of the situation of women, children, and adolescent health in sub-Saharan Africa. I will be talking a bit about why do we have to focus on this group. What is the problem? What is causing this problem? What happens in emergencies like in COVID and other emergencies that we may have? What are the solutions and what Parliament can do? To start, I would like to share with you this slide on what we call the life course approach to health, where we can see the continuum from pregnancy and childbirth through to early childhood, later childhood, adolescence, youth, adulthood, and old age. We need to understand that all elements of this continuum are interlinked, and whatever happens at any stage of the continuum affects different stages of care. And therefore, when we deal with the health of women, children, and adolescents along this continuum, these are all interrelated and they impact the health of the total population up to the older persons. Why do we make such a fuss about women, children, and adolescents in sub-Saharan Africa? We know that women, children, and adolescents comprise the bulk of the population in sub-Saharan Africa. In fact, more than 3/4 of the population is women, children, and adolescents. And these groups are therefore critical if we are to have any development in countries, be it economic, social, environmental. Anything that happens in the country actually hinges upon what is happening in these cohorts. We have also heard and are aware that these three groups are in the vulnerable population. Most of the time, even though they are the majority, they do not have power to make decisions. They don't have a voice and often no resources, especially when they have health challenges. We are also aware that most diseases and illnesses of public health importance, be it HIV, TB, malaria, diarrhea, sexually transmitted diseases, etc. Most diseases disproportionately affect women, children, and adolescents, leading to unwarranted death, disability, and inability to attain their full potential. The mortality rate is also extremely high. In fact, sub-Saharan Africa is contributing the bulk of mortality, that is deaths in women, children, and adolescents in the world, and has the slowest reduction rate as compared to any other region in the world. And if the current pace continues, for sure Sub-Saharan Africa will not attain the SDG 3 targets. The saddest thing is that most illnesses and deaths in women, children, and adolescents can be prevented using very simple and very widely available strategies that can be implemented even in the poorest nation. And this can lead to reduction or prevention of this morbidity and mortality in women, children, and adolescents. We know this because we compare with other low and middle income countries in other regions like the Asia Pacific region, and we find that similar countries with similar demographies and even appear to have more challenges than we have are actually doing much, much better in reducing maternal, child, and adolescent morbidity and mortality. Here we see a snapshot of some of the key problems that affect women, children, and adolescents in Sub-Saharan Africa. And we can see for almost all these problems, it's high prevalence. We actually have high prevalences of almost everything. Pregnancy-related deaths, like you had, we are contributing 2/3 of the global pregnancy-related deaths. In fact, out of the top 20 countries that contribute the largest numbers of deaths in women and children in the world, 18 of them are in Sub-Saharan Africa. The countries contributing the highest mortality rates, they are all in Sub-Saharan Africa. And so this means that we have to accelerate our efforts if we have to reduce morbidity and mortality, that is illness and death in this cohort. Looking at children's health, we still have a lot of deaths of babies, stillbirths, children from things like diarrhea, pneumonia, things that actually we can easily prevent by just having clean water, you know, just basic things that can be done at the household level to prevent these problems. We have a problem of adolescent pregnancy, early and intended pregnancy leading to high school dropout rates, high child marriages, and we also have high HIV/AIDS prevalence in adolescent group, and we have the risk of GBV and other many problems. If we give you the example of maternal mortality, and we have tried to put this graphically so that you can understand actually what this means. When we say we have 202,700 women dying as a result of pregnancy and childbirth in a year, not since God created the earth. That was the 2017 estimate, which is the latest that we have from the global estimates. That is actually equivalent to 500 planes with pregnant women on board and no survivors. Or if you think about it differently, it's 3,400 60-seater buses crashing and no one coming out alive. If we break it down to a daily rate, we have about 550 maternal deaths per day in Sub-Saharan Africa. And these deaths are preventable. if we take one airplane crashing, there will be a lot of pandemonium in the continent. But unfortunately, this is happening in terms of the deaths of pregnant women, and nobody seems to be paying attention to this. When we look at the different countries and where they are in terms of attainment of the SDG target, the SDG target for maternal mortality reduction is that no country should have a maternal mortality that is greater than 140 deaths per 100,000 live births. I believe you can see where your country is in this slide. And if we draw a line at 140 on the horizontal bar, we see that in sub-Saharan Africa, we have only 6 countries that have that maternal mortality that is less than 140. And these countries are Cabo Verde, Algeria, South Africa, Seychelles, Mauritius, Sao Tome and Principe. Out of these countries, some of them started at quite a low maternal mortality ratio and they have made no progress. And so we consider them not to be on track. So from these 6 countries, only South Africa and Mauritius are on track to attaining their Sustainable Development Goal Target 3.1. We can see also from this slide that countries that have humanitarian crises that is sustained or even it comes on and off, we can South Sudan, Sierra Leone, Chad, Central African Republic on your extreme right. And we can see that when we don't have peace, security, or we have other crises, women, children, and adolescents that will tend to suffer, and therefore the maternal mortality ratios will remain extremely high. We'd like to point out that all sustainable development goals are linked. So when we are talking of mothers, children, and adolescents, even though the main targets are under SDG, it affects all other 17 SDGs. For example, if a girl is born into a poor household, that is addressed under target 1.2, and forced into early marriage is under target 5.3. This girl is more likely to drop out of school. Education target is 4.1. Give birth at an early age, that target is 3.7. Suffer complications during childbirth, that target is 3.1. And experience violence, that is 5.2. Than a girl from a higher income household who marries at a later. So there are a lot of determinants that will affect what happens to a girl in terms of maternal, child, or adolescent mortality. Remember that the people who die, most of them are usually in the lowest health quintiles, in the rural areas, without access to services, poor road network, etc., etc. And so we look a little bit at what the contributing factors are. Of all the slides, I would like you to remember this. The first contributing factor we have is political will and country ownership. Unfortunately, in many countries in sub-Saharan Africa, the countries do not have the ownership of the health of women, children, and adolescents, leaving external partners to fund most of the budget for these cohorts. And after some time, when new things come up, we make commitments and we forget everything that we have decided about women, children, and adolescents. Public awareness and social accountability, we find that a lot of communities, the populations, do not own their health. They think it is the government's responsibility to do everything for them. Even now, during COVID, we say wash hands, and they say we need the government to give us water to wash hands. We need communities to own, individuals, families, and communities to be aware of these risks and to own them and to do what they can at their level to mitigate the risk. Legislation and policy environment regarding women, children, and adolescents is often not adequate, and many times we have several legislations or policies that actually don't speak to one another, and we can see examples of that. Multisectoral collaboration, we have all decided that health is the problem of the health sector, not realizing that all sectors actually contribute to health. Remember, the WHO definition of health is as follows. Health is not the absence of disease, but it is the presence of physical, mental, social, economic, psychological, spiritual well-being. And when we look at it that way, then we realize that there are many other performers in health. This is typical in many countries in terms of systems to support the health of women, children, and adolescents. And you can see, and I'm sure you can relate to poor network, poor infrastructure in hospitals, overcrowding, etc. And this really is the main thing that is the problem in the health sector and needs to be fixed. Inadequate health workforce. Almost all our countries are struggling with inadequate health workforce in numbers, in equitable distribution, in motivating them, in retaining them. We have a problem in Africa of generating health workforce, and the best of our health workforce going to work in other countries because we have not put in place retention strategies. And we need to look at our health workforce issues. I've alluded to insufficient financing, and from here we can see that there are high out-of-pocket expenditures which are usually carried by women, children, and adolescents. And like I said before, most women, children, and adolescent services are funded by external partners. And we cannot afford 3/4 of the population for their health issues to be funded, not to be funded from the public coffers. I already alluded to humanitarian and fragile settings. And I would like to say that this is becoming more and more common in the continent, and we have to find a way of dealing with this and ring-fencing health in whichever circumstance we are in. When we look at COVID, COVID has actually unmasked the weaknesses in our health systems. We already had weak health systems, and this has been worsened. And then we have the travel restrictions, the scaling down of routine services, the fears and myths and misconceptions, and all these things are ending up into broken continuity of services for women, children, and adolescents. And we are starting to know a lot of excess mortality that is happening in our countries because pregnant women, children, adolescents cannot be able to access essential health services that they need. If we learn from the Ebola experience, we will realize that the lack of essential health services during Ebola resulted in greater deaths from the other causes than from Ebola. And we need to learn from that and concentrate and make sure that women, children, and adolescents access essential health services. We have several reports from countries. I've put an example there of one report from one country where a certain district lost 4 pregnant mothers in 1 week simply because they could not access health facility because of lockdown. And this is in comparison to last year, where the whole year they had only 15 maternal deaths. If we look at this slide that is showing uptake of services, you can see this is another country that 2017, 2018, 2019, relatively stable, comparable uptake of services, and a steep decline between March and April 2020 because of the COVID pandemic. I would like to say this, you know it, that the greatest cause of death and disability for women, children, and adolescents in Africa is corruption. And we expect Parliament to be the watchdog and to look out for women, children, and adolescents and other vulnerable groups. We have seen a lot of corruption in the health sector in terms of construction and rehabilitation of health facilities, purchase of equipment and supplies, distribution and use of drugs, education of health professionals, research, etc. It is like the money in the health sector is very easy to misuse, and people will inflate things. People will bribe their way for their child to be taken in the medical school when the child has no interest or no inclination in being a doctor. And we shall all agree that we are seeing more and more health providers who it was like they entered the health sector and they had no commitment to that, and the quality of services goes down. We need to learn from COVID, where we find that places where those who could afford could run to and get services outside their own countries, they have closed their borders. And now we must get health services in our own countries. And therefore, we cannot afford to condone corruption in the health sector. And this needs to have very stringent laws put in place by Parliament so that nobody is tempted to do corruption with anything in the health sector. Health is the next most important human right after the right to life. And so what is the solution? There are 3 things I put there to make it easy for you to remember. The will. We must have the will. We must have political will. We know that Parliament is an arm of government. We want to see the will in all of government. Country ownership, commitment. The way. WHO and other technical organizations have put in place, and we have disseminated to all countries in the region what needs to be done, how to do it, and we continually give technical support to countries to help them to customize and to implement the evidence-based strategies. Unfortunately, this is not being done well when they know the way. The wallet. You must put your money where you have realized it is important to you. And as long as we don't prioritize women, children, and adolescents, we are not going to put money there. We must put money, public funds, into women, children, and adolescent health issues. What do we expect from Parliament? I'm sure you are all aware of the millions of statutes, covenants, MOUs, commitments that are signed every other day. If we allude to one, 10 years ago, the third Pan-African Speakers Conference unanimously committed to prioritize parliamentary support for increased policy and budget action on maternal, newborn, and child health in African countries. And they also promised high-level parliamentary support to hasten implementation of the Africa Parliamentary Policy and Budget Action Plan on maternal, newborn health. For us, in women, children, and adolescent health, we believe that we don't need any more commitments to be made. The commitments we have are enough. We just need Parliament to act on the commitments that have already been made. Africa is actually running out of time. Specifically, we need Parliament to advocate and to champion. Parliament straddles the common man and the government. And we expect Parliament, our voice and representative in government. And therefore, we want Parliament to champion the issues of women, children, and adolescents and how to prevent them, especially in the continent. We need more investment and more accountability. Like we have said, the budgeting process should take into account women, children, and adolescent health issues. And we need domestic or public funding. Regulate and legislate. We need a strong enabling policy, regulatory, and legal environment that is responsive to the needs of women, children, and adolescents, and guarantees and protects the right to health and access to quality essential services for women, children, and adolescents. Remember that most of us, even those of us in professional areas, we don't understand legal language. And therefore, when you are drafting these laws, there should be a mechanism in place that assists us to understand, especially those of us who are duty bearers in the provision of health. We need to understand what you are talking about when you make certain laws and policies. With that, I would like to end my presentation. We had a video clip to show you, but it was not working well, and therefore we have uploaded it into the site. And please, we would like you to look at those videos to hear the voice and to hear what we can do as countries to prevent excess mortality and morbidity from women, children, and adolescents.
Thank you so much, Nancy. That was an extremely clear and poignant presentation. I think the takeaways are clear. 3/4 of the population in Sub-Saharan Africa are disproportionately affected by diseases that are largely preventable. And that has an incredible impact on rights, but then also on economies and societies writ large. You've pointed to the fact that weak health systems and poor quality of care are the drivers of this poor access to services, and that Parliament has an incredible role to play in making sure that this is redressed, particularly around stimulating political will, ensuring that there are evidence-based policy legislation that are actively and adequately implemented, I think is one of the concerns we'd heard from Parliament earlier, and that appropriate domestic resources are attributed. I don't know if anyone has any questions, just while you write them down in the chat, if you want any clarifications. Nancy, there is one person that asked specifically if there's anything that can be done to help the adolescents that get pregnant at an early age.
Thank you for that question. We have a lot of interventions that we have recommended. The first and most important intervention is to prevent early pregnancy. In Africa, we have the advantage of having certain sociocultural structures that we can use and that are still operational to protect our adolescent from early pregnancy. If the adolescent is sexually active, we also have a lot of strategies that can be employed, but like we said, a lot of these depend on the legal and policy environment of the country. According to the evidence we have, we find that, for example, contraception is safe in adolescents. But we know that in countries, there are policies and laws that prohibit use of contraception by adolescents, especially in the school-going adolescent. So the strategies are there. We can share them with you, but that is why we say we need a conducive environment to be able to apply the evidence-based strategies. Over.
Thank you, Nancy. Are there any other questions for clarification? Perhaps what I'll suggest as people think through some of these is that we move directly into the second presentation, during which Sheikh Fai, again, the head of APHRC West Africa Regional Office, to talk us through some of the inequalities in women's, children's, and adolescent health.
Hello.
Hi, Sheikh, we can hear you. And just to say that we recognize that this first session is relatively presentation heavy, and we'll have much more time for group work and chats in the subsequent webinars, but we thought that this background information was important, particularly since you asked for it. So with that, I'll turn over to Sheikh.
Good morning, everyone. You could see my my slides, my presentation.
Yes, it's back.
Yep. Are you able to see it?
Yes, perfect.
Good. Thank you so much. Thank you, Kadi. Thank you, Dr. Kaidula. So I think she really deserves a good clap, and I see there is a way of clapping over the Zoom. So that's very nice. So thank you so much for that. My name is Sheikh Fai from the African Population and Health Research Center. We work, we are based in Kenya, Nairobi, and we also have a regional office in West Africa, based in Senegal, Dakar, which I'm heading. So I'll take you through now some facts, some figures around reproductive, maternal, newborn, and child health coverage and aspect in sub-Saharan Africa. So these are now figures, facts that, I mean, this is really in line with what Dr. Kidula has just presented, because that was the overall background, but now we are going to look at the factual aspect. So in this presentation, I'll be focusing on few things, just few slides about what the countdown is, and what also is health inequalities when we talk about inequity. And then I will take you through the main finding that we got from countdown analysis that was conducted recently, and that looked at trends and MNCH coverage in all sub-Saharan Africa countries. But then in the presentation, I may not present for all the African region, maybe focusing on Southern Africa, Eastern Africa, and a bit of West Africa. So, and those findings will be with regard to wealth-related inequalities, inequalities by place of residence, and subnational inequalities. So that's broadly what I will gonna say. And feel free to drop some messages or question over the chat so that we could Okay, so just about the countdown, I'm not sure whether, okay, I should activate my video probably. Yep. So just about the countdown is a global partnership at the global level that it is composed of academics, universities, research institutions at the global level. And I'll show you a slide later about who are those partners, those academic institutions that are there. But then the global partnership just aims to enhance the measurement actually of on elementary coverage and elementary intervention in the countries. So, and also in the meantime, also we have been strengthening capacity of countries to analyze elementary data, to look at inequalities, to go deeper into what exactly we are talking about when we talk about inequalities. So, in terms of product, in terms of product, we publish a lot of journal articles, science fiction, but it's about generating evidence. So we also populate a global report. Actually, even now we are about to publish one of the reports for the GFF mechanism, focusing on elementary in few countries. And then we also produce country profiles. So I think Kadi may have shared with you some profile, country profile. So each country will see the profile. I mean, those are actually equity profiles. And we also have other type of profile on ECD, on other aspects that are there on the website. So you could look at your country, how you are doing in terms of elementary intervention. And then also we provide a lot of tools actually, because that's what we give to countries, to country experts, country government, actually to analyze elementary data. It's also implemented through a regional collaboration. We have 3 regional collaboration initiatives, one in Eastern and Southern Africa, one in West Africa and Central, and another one actually in Latin America, led by the Berkeley University. So when we talk about equity, just starting with equity alone, without even talking about health, this slide actually tells us a bit, and I think most of you actually may have seen this sometime, whereby you see that when we talk about the absence of avoidable, unfair, or remediable differences among group of people. In this slide, what you see is that a few people are holding most of the wealth actually in the US. And this is the fact, this is actually what's happening. And not only in the US, maybe you could talk about many other countries or even over in the world, but this is what it is. So when now we take it to, okay, you're requesting for control of your screen. Okay. So when we talk about health inequities, what we are talking about is that in many societies, it is viewed as a right and not as a commodity. And I think that's very important, that health is seen as a right. And in this vision, each person actually has the right to the best health status, okay? And I think if you take it that way, you could see that when differences between groups are such that it is really unfair, or it is influenced by social or not biological processes, or just unjust. So we could see that that's really what we talk about when we talk about health inequalities. And I just want to highlight this definition that most of you probably may have seen from Whitehead and Daglin. And that says that health inequalities are differences in health status or in the distribution of health resources between different groups of population arising from the social condition in which people are born, grow, live, work, and age, okay? And to illustrate that, look at this slide. Here we try to see, this is actually something that we published in 2012, and it was published in the Lancet, whereby you could see that we looked at several elementary indicators, and we tried to see how it's spread out by wealth and among all the countries. This is a result from 54 countdown countries, and mainly Africans. And by wealth quintile, what are we seeing is that systematically, the poorest are actually lagging behind everywhere. And that's systematically the case for all the indicators. Look at immunization, look at family planning, look at any other thing. But in the meantime, you could see also that for some indicators, the gap between the richest and the poorest is very huge. It's really huge. And for some others, like the early start of breastfeeding, like treatment of bed net. So you could see that the inequalities are really very reduced. But then in the mean, you could see that in all cases, the poorest are really lagging behind everywhere. And that's actually what it is. And this is just with regard to one dimension, which is wealth. But we could look at the same by other inequity dimension that I will focus on. Okay. Now, if you want to now go to the result, the exact result, the result that we got from the countdown. And here, when we talk about elementary inequalities, we'll be looking at 3 dimensions of inequalities. One is, well, as I mentioned. The other one is residence, and the other one will be subnational inequalities. And for each of them, we'll highlight few figures. For the first one on wealth, we just want to point out first the current level. And this is focusing on the most recent survey that happened in all these countries. Here we present only findings in Southern Africa with regard to elementary coverage. And when I talk about elementary coverage, people may be tempted to say, okay, in fact, we have many indicators, yes, but then we try to find a summary measure, we call it CCI, a composite coverage index, which is kind of a summary of the main elementary indicators that gives us an idea of where we are in terms of elementary coverage in that country. And here you could see that in Eastern Africa, from top to down there, you could see how the gap first between the poorest is also is the level of elementary coverage. You could see that in countries like Ethiopia, in Madagascar, Mozambique, you could see the gap really between the wealthiest and the poorest, because remember the reason why we are talking about that, it's about, remember, about the SDG goals of no leaving, I mean the SDG aim of not leaving anyone behind. And here, when you could see that there are such big differences in 12 quintile, you could see that there is a lot probably to be done for countries to reduce inequality. And there you could see that in Eastern Africa, you could see the inequalities are somehow high in some countries, but reduced in some countries like Malawi, Burundi, Rwanda, and so on. But then if you go to Southern Africa, there are 2 things that we want to point out. The first one is that the overall coverage is very high, actually. If you look at that, the average will be around 80 or more than 80, actually. And then for all countries, except maybe for Zimbabwe, you could see that the inequalities are very reduced. So there's probably no significant difference between the poorest and the wealthiest in terms of elementary coverage. And the second aspect is the trends, because we've been looking at the trends since 1995 to see where we are going, whether really this gap is being closed or not by region. And what we are seeing here is that in Eastern Africa and also Southern Africa, the gap is being likely closed in the sense that the difference between the gap between poorest and richest, they are meeting somewhere. And that's really important to highlight. While in West and Central Africa, you could see that there is still a lot to be done to reduce that gap between the poorest and the wealthiest. So that's the main finding of this. And this trend, we have actually more recent trend, but it's not yet published actually up to 2018. But that's the same pace. You will see that in Eastern Africa and Southern Africa, the gap is almost being, is being reduced. And then if you look at also this other slide, if, for instance, the wealth-related inequalities were eliminated in those countries, what would have happened? You could see that some countries will gain up to almost 20 percentage point of coverage. Okay, that means that there is really a lot of things to be done to really maybe adjust or readapt our strategies to focus to reduce those wealth-related inequalities. And in Southern Africa, of course, you could see that they will still gain a lot. They will still gain a bit in elementary coverage. Then impact will be more important in countries like Chad, Nigeria, Mali, all those countries where you see that you could have a gain of almost 20 percentage points. So I think that's the main. If you summarize that, that we could just say that narrowing the gap in elementary coverage by wealth contributes in making progress in national coverage, because that's somehow when you reduce the gap between the wealth and the poorest and the wealthiest, that's also a way of increasing your coverage. Support making it everywhere. You could see that all the region, all the countries, the poorest are always lagging behind, even though the gap is smaller in Southern Africa. Countries can reduce wealth-related inequalities, even in the presence of conflict. And that, because if you look at some countries, at Eastern Africa, and even in Central Africa, which are not presented here, you can see that even in the of conflict, there are ways of really reducing those wealth inequalities. And I think there's a slide I've not shown you that was, that's an study that we did in North Kivu, DRC, which showed that North Kivu and that part of Kivu is really to do a lot into reducing wealth inequality. The second aspect of this presentation is inequalities among by residents. So we try to see between rural, urban are. Just a background to say that, I mean, in the world we know how the urban population is increasing everywhere, so everywhere. And actually in West Africa, you could see that we have 46% of the urban population actually, and in Eastern Africa also the same. So we just everyone wants to be now living in urban area, which is normal because people are looking for a better life. There's a lot of problems, there's a lot of issues, there's a lot of lack of access to social services like employment, housing, and other aspects. And also for that now, we try to focus on two indicators, the child mortality and also the elementary intervention. So in the next slide, I'll talk about child mortality. Look at the trend in this slide, whereby you could see each of the region, the trend between the urban actually are the green one, the red is the rural one, and the blue is the capital, because we try to isolate the capital, because sometimes if you put the capital and all the other urban together, you are tempted to lose a lot of information, because the capital are always are most of the time receiving more information. So here what we are seeing is that, I mentioned recently, the gap actually in Eastern Africa and also in Southern Africa is almost being closed. So there is actually child survival at days, I mean, the child survival event in capital city almost eroded completely in Eastern and Southern Africa. And that's what we are seeing. While in West and Central Africa, it looks like there are still more effort to be done, even though the trend is that it is reducing overall. But then the differences between capital, urban, and other urban is still very, 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 very big. And if we predict the trend in terms of elementary coverage by residents, you could see that, and this is now focusing on all the African countries, the summary, but it's the same pace. You could see that always the rural is lagging behind, and that's what it is, okay? In this slide, we are trying to isolate the poorest urban dwellers compared to the other rural residents. And then you could see that poorest urban dwellers have generally no coverage advantage over rural, meaning the urban poor is behaving almost like the rural. So there's no advantage to be living in urban slums. Actually, that's what this slide is telling you. So meaning that probably we need to also more focus now on trying to see what is happening in urban slums, because they are not really behaving better than those who are living in rural areas. Okay, and these are just the regional figures you could see there. But also, it's also probably due to the fact that the urban slum population is increasing everywhere. You could see in all our countries that, okay, if you look at all the people who are living in urban areas, most likely in almost all the countries, we are almost more than 50% of them who are living in slums. And particularly in Eastern Africa, where you see the big share there, where you could see in Mozambique, Madagascar, all there, even in some other places in Central Africa, you could see that the percentage of urban population living in slum is really huge and is most of the time more than 50% everywhere. So meaning that there is really need to look at actually what's happening in urban slums. And just to summarize that in the fact that mortality and coverage inequalities by class of residents have reduced substantially, actually, because that was the slide that we showed. But then urban child survival and elementary coverage advantage over rural has reduced significantly, and that's the case. Okay, rural areas have experienced faster progress in mortality. But then they are still lagging a bit behind also in terms of being significantly different from the others. And capital cities are losing their primacy in child and elementary coverage, and that one also will actually highlight it more clearly in the next thing, where you could see that living in the capital doesn't mean that we are also having more results, more impact in terms of child survival. There is a large reason urban health inequalities with the rich and urban areas having a large advantage over the poorest in most countries, and that's what we tried to summarize in the previous slides. Okay. Now the last aspect is now subnational level, and here when we talk about subnational, it's different from one country to another. For instance, if you talk about Nigeria, you talk about differences between states. You go to a country like South Africa, you're talking about provinces. Okay. In other countries like Kenya, it's about its country. So that's subnational, which is the administrative unit. So we've tried to see where we are in terms of elementary coverage compared by subnational unit. This map actually is the most updated one. This is a paper from a paper that we published last year that shows us where we are in terms of coverage by subnational unit in all these areas. And you could see that where it is a bit dark, that's where the coverage is much better as compared to where you could see that the coverage is very low. Except, I mean, for Botswana, like unfortunately, we do not have data. I mean, they've not been having survey for years, so we're not able to plot for Botswana. But for all the other countries, you could see that in Southern Africa, things are much better as compared. I mean, a bit also in Eastern Africa as compared to the other part of Africa in terms of subnational differences. So what we are seeing, and that's what actually we want to point out, is that there are large subnational inequalities, no matter which country. There are very few countries where you could see that the subnational differences are very reduced. And if you look at Eastern Africa, we've tried to plot actually the subnational differences by country. And you could see from Ethiopia to Malawi, you could see how the gap between those subnational units is really huge. You could see the big gap in Ethiopia all the way to Malawi. So Malawi is most reduced actually. But then you could see that all the other countries in that region actually are having issues to reduce gaps between subnational units. We've pointed out here in red the capital city, but I'll come back to that. In Southern Africa, it's still the same, but then more limited. You could see that countries like Eswatini, Lesotho, Namibia, I mean, all the countries actually have very reduced subnational inequalities, even though in general, actually, the coverage is really high. You could see that Zimbabwe, Eswatini actually has Eswatini has the highest coverage level in that region. But then if you come to West Africa, it's another story actually, because you could see that from all these countries, there are two aspects here. The gap is actually huge everywhere, almost. You could see from Nigeria all the way to Ghana, the gap between units is very huge. But then there's something very specific, that there is a capital city advantage, whereby you could see that all the capital actually in most of the countries are actually doing very well as compared to all the other units. You could see, except probably for a few countries, maybe Nigeria or actually Ghana, you could see that everywhere else, you could see that the capital is actually where the interventions are focusing. And actually, if you want to reduce those gaps, I think there's need to readapt the strategies. Also look at other units, other subnational units in the countries, rather than just focusing on the capital. And that's what this slide is telling us. So to summarize that, we are saying that countries in Southern Africa showed the highest coverage, and they are followed by Eastern Africa, West Africa, and then Central Africa, where we have the lowest coverage. Coverage. And capital city advantage, so the capital region was higher than in other subnational units in most African countries. And the total exception were actually Ghana and Southern Africa. Actually, all the Southern Africa countries. In fact, we see that the subnational inequalities were very, very limited. And then the capital city advantage seems associated with the national level coverage. I mean, it's normal, because where you see that the national level coverage is very high, like in Southern Africa. So the subnational units, subnational differences are very, very limited. So meaning that everyone is moving together at the same pace, and they are trying to reduce inequalities. And just to summarize that, the persistence of country pattern and subnational inequalities over time, however, does suggest that major efforts are needed to bring down inequalities and reach everyone with high coverage intervention. And high national coverage level can only be reached if we are able to close the gap between regions, between also our capital, I mean, to make sure that we are not only focusing on the capital, but also between all the regions, because you will see that some regions are just forgotten apart. People are not, I mean, government are not really putting effort in some region in countries. So that's really to give in this forum, that it's important to focus on reducing those gaps, to make sure that we are really improving coverage everywhere. And lastly, just to thank you everyone, and these are the countdown partners that have been involved in this work. So just want to thank you very much, and waiting for your comment and question. Thank you, Hadi. Over to you.
Thank you so much, Sheikh, for that presentation. So comprehensive and so much information. And just to note that there were a couple of slides that were taken out. So, you know, happy for all of the participants to put up the more comprehensive presentation so that you get some of the additional information that Sheikh referenced in his presentation. But I think the messages here were clear as well. How rich you are has an impact on your health outcomes and your access to services. But I think interestingly, if you know, wealth-related inequalities were addressed, then that would have a general improvement on health coverage. And also where you live has an impact on how healthy you are. And we have a tendency to understand or know the difference between rural and urban, but where you live within urban settings starts to have an impact, and between capital cities and non-capital cities has an impact. I think the other interesting point that came out in this presentation is this sort of different stage at which countries in different regions are, and we start to see differences between Southern Africa and some of the countries in Western Africa. I'm going to, we have about 20 minutes left, and a couple of questions have come in. I'm going to ask Nancy 2 questions and Sheikh 2 questions, and ask that we remain, or we keep the responses to a minute or less so that we can take more questions. I also know Sheba wants to come in a bit. So first, for Nancy, I mean, Situlu from Zambia asked whether there were any peer review mechanisms available as we move closer to 2030. And Nancy responded in the chat that there are, including the Countdown to 20 report, the SDG reports, and a number of UN reports, including WHO reviews that are conducted. So I wanted everyone to have that bit of information. Nancy, a couple of questions for you. Frank Jenkins asked if there's a link between the political will to address maternal, newborn child, adolescent health mortality and morbidity, and an associated freedom to protest and access to information. So essentially, our countries where we're seeing maternal mortality of 140, are those the same countries where people have little access to information and little right to demonstration? And Frank, correct me if I've read that wrong. There's a second question from Tulisile around what are the causes of political will in leadership, and what can parliamentarians do to increase that? And then Chef, while Nancy responds, a couple of questions for you. One around what measures have led to the reduction of the gap between the wealthy and the poor in Southern Africa? And so what are they doing that countries in West Africa aren't doing? And then I think Tunde also put up a message, sort of a plea, noting the excellent presentation and the need to disaggregate among key populations as well, sex workers, people who reject drugs, transgender people, prisoners, gay men, and so on and so forth. And about, you know, whether there are resources that already disaggregate that kind of information, and whether, you know, the countdown profiles may consider that in the future. So if you can answer, each of you in 1 minute, those two questions each, and then we'll go on to Sheba.
Thank you for the questions. Regarding the first question on the link with political will and the freedom to associate and protest and access to information. You remember I showed how everything is linked. Information is critical for access and utilization of health services. The freedom to associate and protest, I believe those are in the constitutions of different countries and expressed differently there. What you will find that in countries that have access to information, you will actually have even less protesting in those countries, because people usually protest because they don't have access to information. They feel they are not heard, they feel they are not felt. And therefore, as Parliament, you are aware of what is in your constitution that allows access to information and that gives the freedom of assembly and the freedom of airing your opinions. And all those, like we said, come back to the totality of health. That's where Parliament is very, very, very important. When we look at the issue of political will and role of parliamentarians, if we use the COVID example, you will find that countries where political leadership has been strong in terms of controlling the spread and containing the COVID, they are doing much, much better in terms of controlling the numbers and deaths than countries where the political leadership was not very enthusiastic about the COVID responsiveness. So therefore, we see that political leadership in health is very, very, very critical. And when we have the different ministers or politicians attending these global conferences and signing these resolutions, we believe they usually come with the technocrats who are supposed to synthesize this information, to write the country report, to feed back, and to advise them on what would be the best way forward. And we believe that Parliament can do this extremely well, so that commitments are not just on paper, move from paper to implementation. implementation and to dissemination, and we start seeing better results. Over. I hope I've answered your question.
That was brilliant, Nancy. Thank you so much. Chef, do you want to come in on the two other questions?
Yeah. Thank you so much. Thank you, Nancy. Thank you also for the question. I think we will be sharing. I think you will see from the materials more detail on your own country, where you could see the profile and also the publication that we did that we looked at the determinant of what we are seeing. But then the question about why Southern Africa is performing this way, why we are, well, it's almost obvious that we know, I mean, that Southern Africa actually have a history of really high level performance in terms of elementary services, but also it could be linked because I mean, there are other papers that I could share with you that has seen that education and also government also will, because I mean, it's also something that has been documented somehow about I mean, how government is trying to make sure that all provinces, actually all regions in Southern Africa, or most of them, are actually receiving the same services. For instance, you could from the capital to another region, you could see that it's almost the same services or at the same level. So, but it's also due to education, as I mentioned, but we'll definitely share some more. There's a paper that is actually being prepared and published by one of our colleagues from the University of Cape Town about these determinant of subnational inequalities, and I think I'll be happy to share that. And the second one is about this disaggregation at the lower level. Well, in Countdown, we mainly focus on okay, let's say up to 4 or 5 dimensions of inequalities: wealth, residence, how do you call it, urban, rural, and even in some other cases, we looked at differences by education level, actually, and that's something very important. So in this case, those vulnerable groups that you mentioned, we have not looked at it, but there are some aim in actually Latin America in our group there that are looking at, for instance, ethnicities, religion, and things like that, that we also looked at in Latin America, but not yet actually in Africa. But if I see these other questions, they are all important. We may not answer all of them, but just to highlight the fact that, yes, is COVID reducing or increasing the gap? We'll know the answer very soon because we are collecting data, we are putting things together, and there are some papers that will be published very soon around that. But it is likely that it won't be the same story for all countries. In some countries, probably you may see that there is there's an attempt to be probably reducing inequalities, where in others, probably the inequalities may actually increase. But we'll answer your question probably very soon in the coming months. Thank you. Thanks.
Thank you so much, Sheikh. I want to quickly ask if Sheba wants to come in because I'd seen that she had her hand raised, and then we'll take a second round of questions.
Hi, everyone.
Hi.
My name is Sheba from the Ghana Parliament. Can you hear me?
We can hear you brilliantly.
Right. Thank you very much for the wonderful presentations and everything. It's just a quick remark I wanted to make. What I wanted to say was that it's pretty unfortunate that we always get the statistics after the fact, by which time it's already happened and it's after the fact. So there's really nothing much you can do about it. Most of the countries, I believe, have wonderful legislations and everything when it comes to abuse of women, you know, mortality, children, pregnant women, and all that. But I also believe that education is vital in this, because you can have all the beautiful laws, but it's only those who would speak the official language, for instance, who would understand what's really going on. Those in the rural areas will not understand enough to even know their rights. So I believe that we need to decentralize the education. It needs to be broken down into the various local languages for the most rural of rural to understand that when you get to the hospital, you need to be attended to. We also have systems where if you don't have the money, that speaks to the cash issues and the disparity between the rich and the poor. You get to the hospital, the woman is practically in labor, in breach, and all that, and they would refuse to give them care because they don't have the money to pay. That is one thing that needs to be put in all our legislature, that if a woman is brought to the hospital, she can be the poorest of the poor. If she doesn't have the money, you take care of her first, and then you talk about money later. Because we could save a lot of mothers and a lot of babies that way. But it's always, you know, bring the money first. Even if you've got a national health insurance, you need to show it. Where's your national insurance card? Go do this paperwork. By that time, it's too late. You see, the medical officers also need to be educated. It's vital. Can you hear me?
Sheba, go ahead. I think someone
right. I believe also that the medical personnel, the nurses included, need to also be educated to understand that sometimes, you know, in our culture, we believe that the woman should naturally deliver. You understand? But medical science has shown us that sometimes it's not possible. So a woman is in breach, it's not being checked, they say, oh, push, push, push. She ends up dying. You know, so all these things can be brought up, you know, with education. Sometimes you come in there and the best thing they can do for you is a quick CS, and you don't lose baby, you don't lose child. You know, we need to educate people about these things, especially in the rural areas where we have our cultural issues being a barrier. A woman is not supposed to be cut. If she's cut, you know, in CS, it's taboo. But sometimes that's the only thing that can save her life. And women and parents or pregnant people or everyone needs to understand also that the doctors are not God. Sometimes they make mistakes. We've got issues where a mother is lost, a child is lost, a child is maimed, not because that child was naturally like that. It would have been seen in scans that your child has some, you know, deformities or whatever. But in the delivery process, a child is starved of oxygen, is starved of something, is pulled out the wrong way, and the child is damaged. The family cannot speak, because when you speak, it's like, oh, the doctors didn't do it, and you know how they do it. They're going to rally around each other and say, no, 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 it was no fault of the hospital. So a lot of people may know what happened. They feel it's that, look, this is what happened during the birth of my child. My child is damaged, but who is going to believe me? Because it's your word against the doctors. So, and the one thing they can use is, oh, you are in so much pain, you didn't even know what was going on. I mean, honestly, we need to educate, we need to propagate everything, break it down to the local language. Let's prevent, because everything we're talking about now is about after the fact. The woman is dead, the mother is dead, somebody's named and all that, and then we have the statistics and we speak about it. Then we change the laws. Beautiful law. And so what? Who hears it down there? We need to trumpet it every day. That's the little contribution that I just wanted to make. Let's not wait and come up with the statistics. Let's work on it down there.
Thank you so much for that. And I think you bring up very relevant points that I hope both Nancy and Chef will be able to react to in the second responses. So I think the plea for free provision of services for women's, children's, and adolescent in legislation is heard, as well as the focus on education. I think this connects a little to one of the questions that we've received from Leon, who asked, how do you substantially increase the institutional capacity within the health sector while also addressing all of the socioeconomic cultural determinants? Nancy, I was hoping that you could address that a little bit, but there were also a couple of other questions, including on if you have these inequities between rural and urban, how do you ensure that health workers don't refuse postings in the urban, in the rural settings? And then I think perhaps the last two questions that we can try to take from you, Sheikh, in your closing remarks are, Suleiman asks if there's a checklist to assess health inequalities in the different countries in Africa. Is there a standardized one? And Sibonello also asks, who, in addition to the government, are the players that need to be brought to the table in helping to reduce inequalities between the wealthy and the poor in sub-Saharan Africa? And then we can close from there, because we're 5 minutes away from time.
Thank you. I want to really thank Sheba for making it very, very clear and giving us the perspective from your side on how you see these things, and indeed, very, very, very correct. And I want to concur that this is why we really need clear policy, clear legislation to implementation of programs. Coming to Leon's question, remember the definition I gave you about health and the importance of putting health at the center of development. For example, if you improve a road that goes to a health facility because you do not want women to die as they are trying to access health, this road will not be used by women alone, pregnant women alone. Traders will use it to transport their things. Transport will improve. The value of property along that road network will improve. We need to remember that health is the basis for the enjoyment of all other rights. If you don't have health, even if you want the right to expression and to gather, you can't, because the health will make you to stay in one particular spot. And therefore, we need to put health at the center. Once we put this health at the center, from there, we can reach out to socio-cultural determinants of health. For example, we can easily be able to say FGM is resulting in a lot of traumatic delivery and indirect maternal death. And therefore, looking at it from that way, it may be easier to convince people to stop the practice. So putting health at the center, unfortunately at the moment, like we said in the beginning, health is not prioritized by most countries. It is seen as an etc. Sometimes we even look at budgets. We see education gets a big budget, agriculture gets a big budget, but health gets a small budget. And yet you cannot go to school or understand anything if you are malnourished. You cannot farm if you are ill. And therefore, we need to start prioritizing health. And once you prioritize health, a healthy nation will end up being a wealthy nation, and you'll be able to address all these other social and economic determinants of health. I don't think I have any other question. Over.
Yeah, thanks. I think, thanks, Nancy. So just on this question, I think I just want to highlight the fact that health workers are not staying in rural places. I know some of my WHO colleagues here could definitely expand a bit more on that, but the point is that, I mean, you cannot enforce it. I mean, you need there are, in some countries, there are strategies that encourage people to go there because they are incentive, they are more motivated, they are receiving more money. But then it's really something that each country may have to look at closer to see what to do exactly to make sure that health workers are staying in rural places. And I think my WHO colleague could expand a bit more on what they are doing or what the strategy they know. So in terms of also the players, I'm sure so that I know government are the main players, of course, everywhere, because investment funding are mainly coming from the government or through the government. So, but there are many other actors. And I want to highlight the fact that this fight into reducing inequalities is not a public health fight. It's not a public fight. It is a holistic fight whereby you could see the civil society, the media, the researchers, all the other people have to play a role, because researchers are usually just providing evidence, but they are not the best one to communicate, to talk about evidence. So there should be others who will take it to talk about, to see what it means really, when you talk about inequality, what it means, and how to make sure that we focus, we readapt our strategies to reduce those inequalities. So the media also are very key, because there's no way of, I mean, if they channel the wrong message, that's a mess. So I'm saying that this is a holistic fight whereby you could see that all of them could play a role, including academics and civil society and all the other actors. And I think we could also expand a bit more about that. On the checklist, I think there is no standard checklist that we've, even though in Countdown we've been producing these equity profile for each country, we could see that regularly. In fact, we could see that every year, at least we could see the equity profile from your country. But then you could also get it from the national report if you have those national reports. But the problem is that if you use DHIS or routine data, most of the time it's very hard to have those that level of information. So what we do is we use the national level surveys and we dig deeper into it, into doing more advanced analysis to get out these inequalities. But there's no checklist. We just provide it by country based on the data that are available. I think that's, maybe I should stop there, but just to thank Shiba and the other one who were just mentioning very important remark there. So I think we are all on the same page, and our aim, all as health actors, is really to make sure that as Africa and as developing countries, we really reach out there and meet the SDG goals. So thanks a lot.
Thank you, Chef, and I think that's a brilliant place to end, both from you and Nancy. I don't want to take up too much time. I want to thank everyone for participating and for indulging us as we ran 4 minutes over time. And to thank Sheikh and Nancy in particular for their expertise in presentations and everyone who supported the organization of this webinar. I'm sure there are probably a couple of questions that we didn't get to, but this is only the beginning. We'll be together again next week at the same time, discussing the same issue with a focus on legislation, and the week after as well on budgets. So I will leave it here, but only to say thank you. You know where to find the background documents, including the roadmap for parliamentary action for women's, children's, and adolescent health that was jointly published by the Interparliamentary Union and the Partnership for Maternal, Newborn, and Child Health. And to say that we look forward to seeing you next week and to hearing your comments. And again, please feel free to fill in the survey and send any questions you want us to respond to that way. With that, I'm wishing you all a happy end to a Wednesday. Have a good day.
Thank you.